Yeah,
Anthony?
yeah. I think he's right to be very cautious. Firstly, the problems with the tests are whether you get specificity. In other words, are you getting a lot of false positives that actually you're picking up responses to other coronaviruses and not to COVID? So that's one thing. The second is, even if you have an antibody, is it protective? I mean, we actually know that antibodies in this condition are part of the problem, because it's in the second week when you get both your antibody response and the deterioration. And the two may well be linked, that in some ways the virus is clever and facilitating entry into cells, using the antibodies as a way of doing that. And then, of course, there are issues with longer term. We know, for example, with dengue virus, that if you get it once, the second time you get it much worse. So we don't know about the long term. So the idea of an immune passport has been jumped on by WHO and others by saying, look, we really don't understand the immune response. But the other aspect of this is the population side. And Carl could talk to that much better than I could, about why it's so important to know relative proportions, even if you only have temporary immunity.
Carl, do you want to come in on that?
Yeah, no, I agree entirely. In terms of things that matter for policies, particularly sort of shutdown policies, I think that the population, the epidemiological information that you get from serology or blood tests is absolutely vital, because it dictates, as nicely put by Sir Dave, has this thing ground to a halt? Has it exploded? Has it exhausted itself? Or are we in a position of continually damping down little embers and or fires around the country? There is a definitive answer to that. That answer rests upon knowing the percentage of people who have recently been infected and will have raised some antibodies to it. So I think everybody in my world is waiting for the percentage of people who have been infected at this stage in the evolution of the pandemic. Interestingly, in between the cessation of the Independent SAGE meeting and this briefing, there's a paper being released from Heinsberg in Germany, which is very telling. I haven't had a chance to look at the details, but as with some provisional reports from America, it appears that the level of immunity based upon serology is much higher than one might have expected. So based upon their results acquired 6 weeks into the outbreak, it's likely that 10 times more people have actually become infected and raised antibodies. Whether they provide immunity is another question, and time will tell. But just knowing that 10 times more people have actually been infected than would be reflected in the new case reports is incredibly important, because that suggests, in fact, yes, it's probably ground to a halt. And that has enormous implications, not for long-term strategy and testing and tracking. That's a different issue. That's an issue about how quickly does immunity elude or reduce over time, thereby raising the possibility of a second wave in a few months. What we're talking about here is another flare-up in the next few weeks that would be a response to a premature relaxation of social distancing and the like. So if those numbers coming out of Germany now are correct, it sounds as if there's a different kind of social distancing policy that is distinct from the strategy of how we deal with this window of opportunity that is afforded by the fact that the immune levels are greater than they are. So I take your point that, and I think Anthony's point was very valid here, that it would be nice to know if I or my mum was immune and therefore could go to the shops or go to work. And certainly knowing that you've had it is nice for you personally. It resolves uncertainty. That's very important, medically even. However, are you going to take a risk if just because you've got a test that says you've got antibodies that may have 93% specificity which means that there may be a possibility that you're not actually immune. So does it really make a difference personally? And I would argue at the moment, probably less of a difference than the difference it would make to epidemiology and either local or governmental responses to, to how we behave as a society.
Thank you, Carl. Thank you. You got a good answer there. Let's we have to make a bit more progress now. Let's go to Nick Watt for Newsnight.
Thank you very much. It's a question for Professor King. You've been calling today for greater transparency from this government. Is that because you regard this as a government that's getting this wrong, that it's a secretive government, or is any government dealing with an epidemic, a pandemic like this, going to find it fantastically challenging? I'm thinking, for example, of the inquiry into the foot and mouth epidemic back in 2001. It talked about how from the end of March 2001, you, Professor King, were the key figure in the lead. And they said that their job was made extremely difficult because they talked about how they were unable to find a clear account of decision-making around about that time. It said some decisions were made with commendable clarity, others were recorded in a perfunctory way, and some decisions not recorded at all. So I'm interested your views on that.
David.
Sorry, David. I'm sure this isn't the time and the place to go in detail into the foot and mouth disease epidemic. I think that report in many ways was quite right. But I, as Chief Scientific Advisor, took my advice from the Phillips Commission report into the BSE crisis. And that report quite simply said the Chief Scientific Advisor must be able to put his or her advice into the Prime Minister and the Cabinet, and subsequently put the same advice into the public domain, so the public would be able to not only know what the advice was, but could gain the trust of the scientific community in providing that advice. And now, of course, there were other actions taken where I was frankly not involved.
Thank you, David. Can we move on to Michelle Roberts, BBC News? Is she here? No. Okay, let's go to Sky News. Thomas Moore. We're missing our main players. Okay, how about Channel 4 News? Jennifer Sim.
Have you got me now? Sorry. Slight technical hitch. Yes, Thomas Moore, Sky News.
Thomas. Right. Sorry to cut you out. You're in the middle of my screen.
A question for Sir David. I mean, clearly you've had a more public discussion today, but was it genuinely a better discussion than the real SAGE committee?
How would I know? I wasn't at the SAGE committee, and I don't think anyone knows what was discussed in the SAGE committee.
But if there was no great clarity, no great insight, you raised lots of questions and haven't provided an awful lot of answers. If the public was watching, they wouldn't be any clearer now on what your thoughts were on coming out of the lockdown as the week goes on.
This was a 2.5 to 3 hour meeting, and it is only just completed. As I said at the beginning of my presentation, we haven't been able to go through in detail all of the discussions. But what I think would be understood by anybody who watched it was what science in progress looks like. The peer review system where people are challenging each other, people brought in from across the board, different disciplines, from the healthcare community, people from all aspects of the community. So I think the important thing here, we seem to have switched. The important thing here is to demonstrate simply in an open way how these scientific discussions take place. And I would have to say, this was a meeting of scientists who didn't seem to be aware of the fact that anyone was watching them. They were behaving just as scientists would in a discussion of that kind, and no self-consciousness at all.
Okay, I must say I was watching as an ordinary member of the public from outside, and there's a famous science textbook called Conjecture and Refutation, which in shorthand is that science is about contesting ideas arbitrated by facts, and that's exactly what was happening today. However, let's go on. Have we got BBC News, Michelle Roberts back? If not, we'll move on. Channel 4 News. Who have we got for Channel 4 News? Jennifer Sim? No? Okay, there's a BMJ here, Fiona Godley.
Thank you very much, David. I've only got one question to ask, so I'll just choose this one. In the early discussion, someone I think mentioned that elimination was likely to be impossible. And I wonder, I know the vaccine is a long way off, just despite lots of optimism from various quarters. So if we're talking about suppression, I just wanted to hear more of whether you think the government is really onto this, have they really got it? What would success look like at the local and national level, and what would it take to achieve this?
So David, that's for you again, I think.
Well, I'm not sure that it is. I think we've got some experts here who could chip in, Carl or Christopher, perhaps.
Okay, let's start with Carl.
On the basis of the very provisional modelling done so far, you're looking at a meaningful tracking and tracing, whereby you're trying to find those people who are asymptomatic but infected. So the whole point of the tracking and tracing is to go back in time before they can start infecting other people. If there are a suitably small number of people out there that you can identify who have an infection and are likely in the next few days to pass that infection on, who don't know it yet because they're not symptomatic, then it is possible to defer the second wave under the assumption that there is going to be a second wave. But that number has to be small. If you tried to do this after the onset of the outbreak, you would have needed over 1 million tests per day. But if you can use this window of opportunity, the calm after the storm, as it were, where the number of active cases is sufficiently small, you can get away with identifying with a reasonable probability, say 20%, of people who are out there who are infected and asymptomatic, with a logistically feasible testing rate of, say, between 10 and 100,000 tests a day. So I think it's entirely feasible. It sounds to me, and I'm not in a very informed position, but it sounds to me that that's what the strategic aspects of the government's response are aiming at, to set in place the capacity for testing and the mechanisms and the technology, the information science that will be required to backtrace in time those people. So I would imagine that's the most important strategic aspect facing the government at the moment. And I say strategic because there's another side to this, which is something that hit me in discussion with my colleagues earlier on. There's a danger of conflating current policies about how to elude lockdown in relation to social distancing and long-term strategies about suppression. So this comes back to, say, Dave's distinction between sort of the management now over the next few weeks and the strategic suppression objectives over the next few months. So from the point of view purely of the epidemiology and the public health perspective, then that the testing and tracking emphasis, I think, is entirely justified, and from what I can see is numerically feasible.
Okay. Anthony, do you have anything to add to that? Otherwise we'll move on.
Just to say that, of course, there are many countries where this has been shown to work. I mean, if you take South Korea as an example, they'd had 3 deaths by the time they ramped up their testing on February the 22nd. And it basically took them 21 days to get the thing under control. And they've had 250 deaths. So, WHO always say you want to find, track, test, isolate, and do social distancing. But the key thing is speed. And they did that fast. Greece did it fast with lockdown. They locked down before they had any deaths. Unfortunately, on March the 12th, we removed all community testing and tracing, and we also didn't impose a lockdown. And then we hit the steep part of the curve. And so I would infer from that, although others may disagree, that that contributed to the huge increase in cases and, unfortunately, the numbers of deaths we've seen in the UK. Italy also and Spain were affected similarly, and of course the US we know about.
Okay.
David, could I just ask, so we've got the number of tests from Carl, that's really helpful. I wondered about the number of hotel rooms, the number of local people knocking on people's doors, the number of, police. I mean, how are we going to actually get people out of situations where they are going to spread the infection if we're going to actually suppress the disease in somewhere like London?
I'm not sure we have the answer to that, but Anthony, you want to have a go at it?
I would say that's a big gap, and that's what we were talking about today. And yeah, a lot of today was raising questions. One is to have a clear quarantine policy. So, for example, in Northern Ireland, they have a policy where they tell you to quarantine for 7 days, but in Southern Ireland, they abide by the WHO rule, which is 14 days. And there's one city that is on both sides of the border. So that's a bit difficult. But you're absolutely right. You need to have a policy about if you're sick, you go to hospital. If you're not so sick, how are you going to be taken out to be isolated, particularly for vulnerable groups or women with domestic abuse, which Zubaida could talk to? Or, and then how do you isolate contacts? And certainly in China and many of the Asian states, they did requisition hotels to do that. I haven't seen the quarantine policy that has come out yet, but I think that needs to be interrogated.
Okay, thank you. Should we try Channel 4 again? Is Andy Lee there? No? Nobody on call? Okay, we'll move on.
Hello, sorry, I'm here. I just took a moment to come off mute. I've just got a very quick question, which is, do you have a view on which mobile track and trace system we should be using, whether we should be going with the centralised route, which seems to be the favourite of the British government, or whether we should go for the decentralised Apple Google approach?
All right, that sounds like one for Carl again, is that right?
Sorry, I'm smiling because I'll make something up. It's a great question. I personally can't give you any informed answer at that, other than to just reflect upon something that came across very strongly for me, which is a new thing from our discussions, which is this choice you have between centralized and decentralized, local versus federal approaches. I got the sense that the consensus was, and this certainly is underwritten by numerical analyses and simulations of whether in the United States of America you should devolve reactive, adaptive policies to each governor as opposed to to a federal level. The advice would probably be to de-regionalize, decentralize, and put much greater emphasis on primary care and empower local resources. Now, whether that comes along or is facilitated by having a local Apple Google approach as opposed to a centralized one, I don't know. My guess is it probably would be.
Okay, thank you. Let's go to AP, Jill Lawless. Is she there? No. All right, we'll try PA, Nina Massey, science correspondent. No, our comms not working today. Okay. Guardian, Nicola Davis.
Hi, hello. So it took me a second to get myself unmuted. Yes, I have a question for Carl, and I just want to clarify something because it really jumped out at me what you were saying about this paper in Germany. It sounds like what you're saying is that this virus, if 10 times more people have actually had coronavirus than test results suggest, which I think is what you're saying this paper says, it sounded like you were saying that means that this might just fizzle out. Is that what you're saying? I'm sorry, I just want to clarify.
I think fizzle is an interesting word. It certainly harps back to the metaphor we were using earlier on about the difference between a smouldering fire and an exploding firework. So in the sense that fizzling is an attribute of a firework, you're absolutely right. But I would frame it more like a storm or an explosion. But the sentiment of your question is absolutely right. So 15% of the population were seropositive 6 weeks after the outbreak in this relatively hard-hit region of Germany. That is consistent with a model of how the population responds, or at least the effective or susceptible population responds to an outbreak, where there's this self-organized attenuation of the spread simply because there is no more combustible material for this virus fire to consume in the short term. So that's, if you like, the optimistic outcome, that in fact it is less virulent than one might have imagined, and that more people have at least a short-term protection, and thereby will attenuate its spread when we go into a relaxation of lockdown. So, but these are very provisional data, and perhaps it's just, I'll close by making another point which came across to me very strongly, that the emphasis now from the point of view of people thinking about the policy and the likely outcomes of the next few weeks is not on vaccinations. That's an issue for, you know, over a timescale of years. It's really getting a good handle on how many people have been infected, so we understand the consequences of exposing ourselves to each other again.
All right, thank you, Carl. Now I'm going to give notice. I'm going to try the Financial Times, then the Lancet, then the Sun in that order, if they're around. Let's start with the FT. Is Camilla Hodgson there? Or anybody?
Yes, can you hear me?
Yeah, gotcha.
Great, thank you very much. I wanted to ask, first of all, views on the partial membership list of SAGE that we saw published today, and also to ask about the importance of publishing the minutes and the evidence, which we don't yet have, particularly as it relates to the decision to allow that 2-week gap between ending contact tracing and beginning lockdown, which Anthony Costello mentioned.
Oh, that's a question for me. Well, as I've already said, I'd like to see both the minutes and all of the recommendations and dissenting judgments. That's how science works. But I'm not presenting my views today. I'm presenting the views of the committee. Can we move on to the Lancet? Richard Horton, is he there?
Yes, thanks very much. It's very clear that COVID-19 has revealed and exploited and accentuated inequalities, both socio-economic and... What were your recommendations for government as to how, first of all, they should be protecting the most vulnerable in advance of a second wave, and then looking further ahead, what their policy priorities should be for addressing inequalities in the future?
Can we bring Zubaida in on this? I think this is one for you.
Yes, great question, Richard. Thank you very much. We actually talked quite a lot about this, which was important in the context of the fact that this crisis isn't just a health crisis, it's also a social and economic crisis. So it's very important to think about what's happening to vulnerable groups. Now, one of the questions we were considering is, have the government's current economic measures sufficiently covered or sufficiently shielding or protecting all the vulnerable groups out there? And of course, to a great extent, they're not. The government have thought about employees and they've thought about self-employed, and of course you have the universal credit. But the concerns that I raise, which are also coming from the women's sector, which is also coming from the migrant sector, were twofold. One is that at the moment, the economic safety net for people who are vulnerable and on the margins of poverty is simply not enough. It's not enough. Universal credit has all sorts of constraints that I'm sure many of you are familiar with: the 5-week wait, the 2-child limit policy, the housing benefit doesn't cover many of the housing that people live in. So there are real constraints there, and that needs to be strengthened much more, including child benefit. Child benefit is not enough. It needs to be increased to £50 per week per child. Now, the reason we mention that is because if you don't have a sufficient economic safety net, then that really compromises social distancing, because there are people who don't want to go out to work because they're not supposed to right now, but are forced to work because the economic safety net isn't there. The other thing that we raised is the fact that the government's no recourse to public funds is severely constraining a lot of different groups, and these aren't just migrant groups without leave to remain. There's all sorts of groups, including NHS workers who can't get access to benefits, to NHS care, to universal credit, to council tax rebates, and so on. And we're asking those to be scrapped. We think those are important because at the moment, these groups are, I mean, the government simply haven't considered them. The government have sort of ignored them. It's been a one-size-fits-all kind of policy. I mean, I'll stop there, but if you want to ask me a follow-up question, I can answer that as well. Sorry,
Thank you.
One other thing I wanted to add is the other issue I wanted to add is the other area that the government haven't planned for, and to be honest, they've been dragged here by civil society organizations, are the social consequences of COVID-19. And the social consequences have been predicted from the outset, and those are the absolutely enormous increase of domestic abuse. Women's organizations have been saying that from the outset, that if you have lockdown, which of course is compulsory, but the consequence of that is that victims are then locked in with their abusers. And the government had to, be forced into a place where they gave a bit more funding, but it's not enough. It won't be enough now. It's not enough, and especially when it comes from exit to lockdown, because that's when we're going to see more women coming out and saying, please help me, I need refuges.
Thank you, Zubaida. We'll move on now to the Sun. Nick McDermott, are you there? Or Sean Muller?
Yeah, hi, it's Sean. Thanks very much. Question for David King for me. Wonder if you can detail one finding from your meeting today that you think will have any influence on the government's exit strategy.
So, David.
We can only hope that it will do. I think we've put together a team that are really right across the board. We've just heard Zubaida giving a particular view, and we had a very good discussion. I have no idea what the advice is going through SAGE, but I have a feeling that any group of this quality would be able to put in advice that government would respond to.
Okay, what is the one piece of advice you would hope they would take away from this?
Well, the advice that Zubaida has just given, for example.
Thank you.
Thanks, David. Victoria Allen from the Daily Mail with us? No? All right. Matt Roper, Daily Mirror? Okay. Susie Ring from Bloomberg? All right. Adela Whittington from the Daily Star? Now we've lost our audience.
Can we go to David Shookman, BBC News science editor, has his hand up.
Yeah, where is he? You got him? David, you there?
Hi, I'm here. If you can all hear me, I hit the right button.
Oh yeah, we can see you too.
Thank you. Could I ask for some thoughts about the R number, which seems to have become so central to the next steps, and really how accurately you think we actually understand it, in particular when it comes to the effect of lifting different measures, what effect that would have on the R number. Could anybody comment on that?
We start with Anthony on this one. Anthony, you've gone silent.
I was going to say Carl is much better on R0s.
All right, we'll give it to Carl. Carl, you want to take it?
Yes, my favourite statistic. So just technically, and I've noticed, David, that you do a lovely piece on the news explaining the R as a concept and a concept. R0 is the basic reproduction rate, which would only be relevant as a statistic or a characterization of the spread of the virus at the beginning of the outbreak, because it pertains to and only to the susceptible population. So we're talking about the effective reproduction ratio, or just R itself. The point being made in the independent SAGE discussions was that R in and of itself is not a cause of pathology, death, suffering, or any other measurements of those things. It is a descriptive statistic or a summary that can be best thought of as the local shape of a curve. As such, it may not be the best way of quantifying, modeling, or conceiving of what is actually causing the infection and the various ways in which it manifests. So I know this because I've checked it on Wikipedia. So you can go and check it on Wikipedia, and one of the first things it says is, it is not a biological constant. It is not a fundamental construct that is responsible for causing the outbreak. So my attitude to that as a modeler is that it is a consequence, not a cause. Is it a useful consequence? I would actually submit it's not terribly useful because it post-dates the causes. So a lot of the operational and important decisions when it comes to policies rest upon what will happen if I do that. But that will happen in the future. So what we need are the metrics and estimates of the causes of what will happen in the future, which is effectively the prevalence of population in the population at the present time when it comes to policies about the next few weeks. So R is a post hoc reflection. It's a nice statistic. It's easy to model. However, it's not really the thing you should be aiming at. You want to know what caused the R several weeks in advance so you can proactively adjust your policy so that the consequence of R is suitably ameliorated.
But sorry, presumably to get to that position, that's where testing comes in on a really grand scale.
Any data that you can generate with a model, which technically a generative model or a forward model that generates data, will make use of any data that's available. So your observation is absolutely correct. The more data you have, the more of it, the different kinds of data that you have access to will all shrink your uncertainty about these estimates of the things that matter. So a simple example here would be the prevalence of infection at this point in time. If you can estimate that very, very reliably with lots of data, with good models underneath those data, then you're in a very strong and quantitative position to write down a very simple policy that will ameliorate the outcomes that you don't want a few weeks in advance. That will be expressed in the R, but it is not in itself, I repeat, the R itself. The R is a description of the dynamics. It's not a cause of the epidemiology itself.
Thank you. Great.
We're down to our last minute now, so let's see if we can get ARD, the German news channel, on. Are you with us, ARD? Annette Dittert or Sven Lohmann? No. All right. How about the Daily Telegraph? Henry Bodkin, are you with us? Bloomberg, Susie Ring? No, we seem to be out of listeners. Anybody else? Economist, Natasha Loder, you with us?
Oh, hi, yes. Sorry, I missed the preamble. Did you talk at all about vaccines and about the priority groups for vaccination that might be considered later on in the year?
David, so David, would you like to come on?
We did discuss vaccines fairly briefly. We did feel that vaccines shouldn't be overstated as a solution. I think many of us do hope that a vaccine will emerge, that it'll be properly tested, and that it'll be manufactured at scale so that it can be rolled out not only in this country but abroad. We just got to remember that this pandemic, it cannot be fully opened up in the sense of returning to our globalized society. We all have to have this under control. And of course, if there's a good, viable vaccine going, that would be wonderful. But we certainly don't feel that we can rely on a vaccine emerging of that quality anytime soon.
Thank you.
And what about priority groups? When we do get a vaccine, do you have any thoughts about priority groups of vaccination?
Let me pass that on. I don't know if Alison is still with us or...
Alison, would you like to take that?
I'm not sure it's really my area of expertise, being a critical care doctor. But one of the things I would like to take the opportunity to say is that everything that the government has done in terms of lockdown and everything else is to try and protect the NHS. And the only way certainly critical care has been able to cope is by staff stretching themselves, sharing their skills, and other staff as well. And as we move into the second phase, we're obviously trying to reinstitute normal services, but we're not going to be able to do that unless we make sure that we focus on staff health and well-being, and also take the opportunity to reflect on how we've got to where we are now, and maybe reconfigure services, not in the long term, because they may not be appropriate in years to come, but certainly to get us through this next phase, we may need to reconfigure services and also make sure that we can discharge patients more quickly into the community and provide that community support that certainly patients who've been critically ill are going to need.
Good. Suppression, you want to come in?
Oh, yes. I was just wondering if I could add to that. I mean, it's an interesting question about who do you prioritize for vaccines. It's also a controversial question. It's not an innocuous question. But I think, you have to go back to the data. And what we do know from the data at the moment is that as well as older people being extremely vulnerable to COVID-19, we have some ethnic minority groups who appear to be very vulnerable to COVID-19. And on top of that, we know that people in deprived areas are twice as likely to die from COVID-19 as those from non-deprived areas. So I think to a great extent, we need to look at the data and work backwards in that way in terms of answering the question of how do we further protect and shield those groups from COVID-19, from the health front of COVID-19.
Zubaida, thank you very much. We've overrun our time by 5 minutes. David, you have any final thoughts to give to the assembled journalists?
No, thank you.
That's the trouble with science. They never do what the politicians expect. Thank you very much, everybody. Thank you. Session's at an end.
I should have thanked you, David.
No.
Thank you very much.
Thank our techies for keeping us online. It's a bit of getting alarming.
Well done. It was really interesting. Thanks for doing that.
Robert, nice to talk to you.
Much later. Cheers.
All right. Nick, I think I'm talking to you later.
Yeah, thank you.
All right.
Thanks very much for that.
Very good.
Thanks, everyone. Very good.
Thanks, guys. Apologies for the technical mishap at the very beginning, but we got back online fairly swiftly afterwards. So yeah, my apologies for that.
Yeah, I couldn't quite work.
Thank you to Zach for sorting it out, by the way.
Yeah, well done. Well done. I always thought the Zoom fell to bits after 45 minutes, so we were living on borrowed time for 5 minutes there at the end.
Yeah, no, it's okay. I spent 15 quid in a premium account, so we could get another hour out of it if we needed to. But thank you very much. That was great. That was really, really good.
Okay, thanks very much. All the best.
See you. Bye-bye.
Thank you. Bye-bye. Thank you.
Take care.
And you.
Thank you, David.
Thank you. Bye-bye.
Bye-bye. Thanks, David.
Bye now.
Too many Davids.
Both Davids.
I'll be Dave.
Dave and David.
Yeah.
You're Dave.
Yes.
Gosh.
My mother only called me David when she was angry with me.
My mother was the same. Bye now.
Thank you. Bye-bye.